Okay, so for introduction, my name is Bill Lombard. I've been in Bellingham since 1981. I retired from a practice of nephrology, which is a internal medicine specialty of kidney disease, in about 2015. That was the first time, and then I retired 2 more times after that. I went back to work intermittently, and finally, about a year and a half ago, um, stopped practicing. I was the director of the Mount Baker Kidney Center for about 25 or 28 years. And that and my practice during these years showed me what patients with kidney disease go through and what patients on dialysis have to endure throughout their lives on dialysis. And it has always been my passion to help them in any way I can, and also to try to prevent this disease from impacting so many people. And that's what we're going to talk about today. So I'm here's a member of the Mount Baker Foundation. It was formed about 5 years ago when the local Mount Baker Kidney Center was sold, the Mount Baker Kidney Center was a not-for-profit, community-owned and based organization, was sold to DaVita, which is a for-profit. And the Mount Baker Foundation was formed as a beneficiary of the funds from that sale, and as a legacy of that organization. One of the focuses we have maintained is the care and quality of life of patients with kidney disease. And in the process of that, both from input from people who work in the kidney center and from a questionnaire that we supplied to dialysis patients, it became clear that patients really feel that very few people, first of all, know much about kidneys or know very much at all about kidney disease. And many of these people are absolutely shocked when they find out that they have kidney failure. And so we've started a kidney health initiative, which is being kicked off March 1st, which is National Kidney Month. And you'll see banners around the town. And we're going to talk about that today. So I'll get my screen up here. Chronic kidney disease has been called the silent epidemic, and it's called silent because, first off, most of us are unaware how many patients or people are out there with chronic kidney disease. And secondly, many of the people with kidney disease don't know they have it. And it is certainly epidemic by virtue of its proportions. As it turns out, 1 in 3 of us are at risk for having kidney disease. And if you look at the gallery screen, look at your person to the right and the person to the left and yourself, statistically, one of you has a risk factor for kidney disease. And how do you know if you are that one? Well, looking more at the numbers, 15% of US adults, or 37 million people, are estimated to have chronic kidney disease, according to the CDC. Interestingly, only 1 in 10 of them know they have it. Furthermore, 1 in 2 patients with very low kidney function who are not yet on dialysis, but shortly will be, do not know they have chronic kidney disease. In Bellingham, it's been our experience that between 30 and 50% of the patients that start dialysis arrive having never seen a kidney specialist and with very little knowledge of their kidney disease or kidney failure, which is a real problem because if you don't have adequate education and preparation for end-stage kidney disease or kidney failure, it's going to make it a much more difficult road and significantly increases the risk of having a bad outcome in the first year. Furthermore, a recent study was published just several months ago that looked at all veterans coming for dialysis, and 60% of those had never seen a kidney specialist. So the clue is silent by people not knowing they have this, and furthermore, by just not being adequately, and important, not being educated about it. If you take it a global view, and this is just the 10,000-foot view, 780 million people worldwide are affected by chronic kidney disease, and millions die each year because they don't have access to affordable care. 2 million people receive treatment by dialysis or kidney transplant to stay alive. Unfortunately, this only represents 10% of the people who need this treatment. And those 2 million people are primarily housed in the United States, Japan, Germany, Brazil, and Italy, where they are able to obtain treatments for their disease. Any questions about that so far? Okay. We're going to talk about what the specific risk factors are, but right off, I want to point out that 1 in 3 of adults with diabetes and 1 in 5 adults with hypertension very likely have kidney disease. So, again, talking about the high frequency of the disease. So many people don't know what kidneys are or what they do, and the next couple of slides will address that. Kidneys are located on either side of the spine, in our back, just at the bottom edge of the rib cage. They're a fist-sized organ, which you can see on the right. This is actually a kidney that has been harvested for donation. And if we start off pretty healthy, do perfectly well with only 1 kidney, making it very convenient to donate a kidney. And what do our kidneys do? Well, first off, they regulate blood pressure. They do that by secreting hormones into the bloodstream that both increase or lower blood pressure, depending upon what the kidney senses is the need at the time. They activate the vitamin D that we obtain from the sun and from supplements to the form that allows it to increase calcium absorption from our intestinal tract and increase our bone strength and health. It produces a hormone, erythropoietin, which causes the production of red blood cells. Generally, about 120 to 150 liters or quarts of fluid are filtered by the kidneys each day. And the kidney actually reabsorbs more than 99% of that back, so we typically would excrete a quart and a half of urine. But we also, in that quart and a half, leave the waste products, but take back from that 120 quarts the things that the body needs to keep, like glucose and sodium and calcium. And then the body balances the body, keeps the body's internal fluids balanced, and basically maintains the internal environment of the body. Anybody have any questions about that? We'll have time at the end for more questions as well. So what are the risk factors? What things put us at risk for developing kidney disease? Well, the biggest one is diabetes, which accounts for about 50% of the people that start dialysis each year. High blood pressure oftentimes coexists with diabetes and aggravates that risk factor, but it by itself is also a risk factor. A positive family history is also significant. If you have anyone in your family who has been on dialysis or had kidney failure, that places us at risk. Different ethnic groups, particularly African Americans, Hispanics, and Native Americans seem to have a disproportionate risk for kidney disease for a number of reasons. Over the age of 60, kidney function tends to slowly decrease, plus we all accrue a certain number of medical conditions or diseases as we progress in our age, and that also is a risk factor. Finally, heart disease, particularly heart failure, carries about at least a 30% risk of chronic kidney disease. This just looks at the percentage of chronic kidney disease amongst U.S. adults aged 18 and older by age, sex, and ethnicity. This is just to point out, again, that as we get older, there's a higher prevalence of chronic kidney disease, roughly 35–37%. Women are slightly more likely to have kidney disease, but as we'll see later, they're less likely to end up with kidney failure. I think it says something about how guys take care of ourselves. Non-Hispanic whites, the prevalence is around 13%. Non-Hispanic blacks is around 17%. So there's a disparity in the number that have chronic kidney disease, and that is much higher in terms of those that actually go on to dialysis or end-stage renal disease. For Asians, it's lower, and for Hispanics, it's slightly higher than non-Hispanic whites. Okay, so how do I find out if I'm the one with a risk factor for kidney disease? Well, there's a really convenient website. If we were to log on to this or click on this link now, it takes you to the National Kidney Foundation website, which is called Minute for Your Kidneys, where it is a 5-question quiz. It truly only takes about a minute. It asks if you have ever been told you have diabetes, if you have been told you have hypertension. It asks you about family history, about ethnicity, and then asks about your height and weight. And then you push the button and it'll say you have no risk. Great. Or it says you do have a risk factor. And then we'll ask you if you want to be sent a urine test you can do at home, which looks to see whether or not you have protein in urine, which would mean you do have evidence of kidney damage. And that's all for free. It's very convenient and very easy to do. I actually filled out the questionnaire myself and put in a couple risk factors and said I wanted the home test. I don't have it with me right now, but it's a very convenient little collection cup and a dipstick, and then a little grid that you take a picture of with your smartphone, and then you put the dipstick in it, and it reads off what the protein level is. When you do put in the risk factors or ask for the urine test, the National Kidney Foundation stays on you. Once a week, you'll get an email saying, have you checked in with your doctor yet? We haven't seen your urine test yet. What's up? And I actually got a phone call from them a month after I filled it out saying, we haven't seen your urine test yet. What do you need to do this. It's really important. So this is a really great place to start. And if you think you might be at risk or want to find out if you have a risk, please take the moment to do it because it really is worthwhile. The next obvious thing to do is when you go to see your doctor next time, ask him if you have any of the risk factors or you should be worried about it. He can do a urine test to see if you have protein in your urine, can do a blood test, which will show what your kidney function is. And if you want to know more about it, go to our website, themountbakerfoundation.org, and you'll see a banner at the top asking if you're the 1 in 3 and talking about the importance of kidney disease with a lot of good information there. So what if you are the one? What if you are the one at risk? Well, if you are, your physician will monitor you regularly to see if your risk is actually causing problems with your kidney function. You'll have blood tests and a urine test done periodically to see if you should be sent to see a kidney specialist. And the kidney specialist will then co-manage your care with your primary care doctor, and they should be consulted if there are any changes in your condition or changes in your medications as time goes on. So if I have chronic kidney disease, how can I lower my risk for progressing to kidney failure? And the truth is that chronic kidney disease, no matter how well it's treated, in most people will be progressive. If it's not treated at all, it will progress fairly rapidly. If it's treated well, it can be delayed or even prevented from proceeding to kidney failure. So it's really important to find out if you have this and get treated early, and diagnosed early and treated early. So if you do have chronic kidney disease, learn from your kidney specialist, your nephrologist. Are there specific treatments for my particular type of kidney disease? And are there particular medications I should be on that will slow the decline? If you have diabetes or hypertension, be sure that those are at the prescribed goals. The A1C will vary depending upon, for example, if you have diabetes, there's something called an A1C hemoglobin, which tells you what your average blood sugar has been for the past month. And your physician should set that goal for you depending upon the type of medications you're taking. For blood pressure, if you have do not have protein in your urine, then the standard is typically less than 140/90. And if you have a significant amount of protein in your urine, it should actually be lower in the range of 125/85. I'm sorry, 75. In terms of managing chronic kidney disease, a healthy diet is important, particularly one low in salt, low in fat, and getting routine exercise. We should try to maintain an ideal body weight as best we can, because that will contribute to both blood sugar and blood pressure control. Use the medications that are prescribed for you, which will slow the decline of the kidney function. Work with your healthcare team to monitor your kidney health by your blood tests and urine tests as they see appropriate. Typically, it may be once a year. If your kidney function declines, some may go up to every 3 to 6 months. And people who have very severe disease, oftentimes we see them once a month or even every 2 weeks. Stopping smoking turns out to be very important. There have been studies which show that it does contribute to the progression of chronic kidney disease to kidney failure. And then next, you really want to avoid those things that can harm your kidneys, mostly certain medications, particularly the anti-inflammatory drugs like ibuprofen or Aleve. Those have been shown repeatedly to be damaging to kidney function. There are certain antibiotics, particularly sulfa drugs, which can damage kidneys. The acid-reducing drugs, omeprazole or Prilosec or Prevacid, they have a low frequency of an allergic kidney reaction, which causes slow but progressive kidney failure, which if it's not stopped can be damaging. It's generally a low enough frequency that it wouldn't be important, except that there are so many people taking these drugs that we end up seeing a half a dozen patients a year with problems related to that. If you're taking any supplements, you need to make sure that those are okay with your nephrologist or your primary care doctor. And then the dye that is used for CAT scans and heart catheterizations, the intravenous contrast dye, can be damaging to your kidneys. So it's always important, if any test like that is ordered, that you be sure to comment if you have kidney disease, that could be a problem for you. So when kidneys fail, what are the long-term treatments? Well, the ideal treatment early on is a kidney transplant. If kidney disease is progressing slowly, the ideal thing is to find a living donor who's willing to give you one of their spare kidneys, share a spare. We know that they can get by with just one kidney, and the other kidney would certainly help you tremendously. The biggest roadblocks are usually finding the kidney that matches you, and if you have a live donor who's willing to give you a kidney and it doesn't match you, the kidney transplant centers are oftentimes able to find someone else in the same circumstance where their donor may match you and your donor may match them, and you can actually swap the kidney, which is certainly helpful, because then for each of those donors, we have 2 patients coming off of dialysis or being spared dialysis. Dialysis is performed either in the kidney center or at home. There is a type of dialysis where a catheter is placed in the abdomen called peritoneal dialysis, which is a very gentle, continuous form of dialysis. There also are machines that can do hemodialysis, such as this gentleman, that can be done at home as well. It's typically done for a shorter time, 5 days a week, rather than the usual 3 days a week that is done in center. It can also be done overnight for 3 to 5 times a week, usually 5. And those patients generally really feel quite good. And then finally, palliative care is sometimes the best option for some individuals who really can't tolerate dialysis, or it's just not appropriate for them. These are typically the frail elderly, and there have been a number of studies which have been conducted which show that for that group of patients or people, they actually live longer and stay out of the hospital and have better quality of life rather than proceeding with dialysis. There's just some facts about end-stage renal disease. These are people who have complete kidney failure. In 2019, 125,000 people started dialysis for end-stage renal disease. And at that time, the prevalence was 750,000 were on dialysis or living with a transplant. Every day, 340 people on the average start dialysis, and 240 people who are on dialysis die. Interesting fact is, remember we said before, is that women tend to have a higher frequency of urinary tract, chronic kidney disease, but there are actually less women on dialysis than men. And this turns out because probably the women's chronic kidney disease relates to recurrent urinary tract infections, which is so much more common in women than men. And frankly, I think women just take better care of themselves, tend to follow doctor's orders better. African Americans are 3 times more likely than whites to develop end-stage renal disease. And I think if you recall back to that previous slide, there was only a slight difference in the prevalence of chronic kidney disease, and yet African Americans are more likely to progress to kidney failure. And unfortunately, I think this is a statement regarding the inequity of the care they receive or their inability to obtain adequate care. Hispanics, likewise, which were only slightly higher or similar to whites in terms of the prevalence of chronic kidney disease, are more than 50% likely to develop end-stage renal disease. And again, I think this relates to the same factors that impact the African Americans. And as we mentioned earlier, in the United States, for adults ages 18 and older, diabetes and hypertension are the main causes for people developing end-stage renal disease. This is just a look at what the actual impact, socioeconomic impact, is for chronic kidney disease and end-stage renal disease. The employment rates average for the age group of 18 to 55, 23% at the start of dialysis, whereas 6 months earlier, 38% of those people were working. And if you look at a comparable age group without kidney disease, 81 to 83% of those people are employed. And again, this is pre-COVID, I know, but just give you a rough idea that this is a group that is impacted by the disease and not able to lead a normal life. Medicare eligibility begins automatically at on the start of the 4th month after starting dialysis, which is an entitlement program which started, I think, in 1973, because it was very clear that no one could really afford to pay for dialysis care on their own. The per treatment cost for Medicare is $248 per dialysis treatment, whereas if you have private insurance or you are paying out of pocket, the cost is closer to $1,041 per treatment. And when you average this out at 13 treatments per month, if you have to go 3 months before you start getting Medicare coverage, the cost is going to be up in the range of $36,000. When you look at the Medicare cost per year for a patient on dialysis, is about $90,000. If you do the math, you'll go, well, if 248 times 13 doesn't come out, and times 12 doesn't come out to 90,000. And that's because dialysis patients on average are hospitalized 2 to 3 times a year. And they also require a number of procedures to maintain their blood access for dialysis. So it ends up being a very costly endeavor. When you look, patients on dialysis make up only 1% of the Medicare population, but they account for 7.5% of the Medicare costs. And in 2017, treating Medicare beneficiaries with chronic kidney disease cost $84 billion. And the treatment of patients on dialysis cost an additional $36 billion. It's a very costly disease. And another little fact about chronic kidney disease many people don't talk about, and I'll explain this graft in a second, is that it's a disease multiplier for cardiovascular disease, particularly in patients with diabetes and hypertension, which basically means down the road, these people are going to have a higher rate of cardiovascular complications and earlier deaths because of it. And this is cardiovascular deaths. And this 60 is the cutoff for kidney failure. And if you look and you have no protein in your urine, your adjusted risk is 1 or 1.2, which is trivial. But if you have a lot of protein in your urine, which is this red graph, it's now excuse me, a fourfold increase in your risk for cardiovascular death. And as the kidney function is lost, so this is lower kidney function, this is higher normal kidney function. As you get lower, this is now up in the range of 6 to 8-fold increase in cardiovascular mortality. So, in summary, kidney disease risk and occurrence or prevalence is much greater than most of us know. Finding out if you're at risk or have signs of kidney disease is actually quite easy, and the minuteforyourkidney.org is the easiest way to do it at home. And it's important to find out early so you can be treated early, so you can prevent progression and or complications from the disease. And our goals of our Kidney Health Awareness Initiative are that by increasing the community awareness of the risk and prevalence of chronic kidney disease, patients can become self-advocates to identify and seek help to manage their risks. By reducing the burden of kidney disease on individuals and the general population, we can prevent its occurrence by treating the risks, that is controlling blood pressure and controlling diabetes, which are the two that we can do something about. Can identify chronic kidney disease early, treat it early and delay its progression or even prevent the development of end-stage renal disease, and also increase the number of living donor kidney transplants. Before we get to the questions, just want to tell you a little bit about the Mount Baker Kidney Center. We consider ourselves a catalyst for community and generational transformation. Our vision is that individuals, families, neighborhoods, and communities become stronger, healthier, and more resilient and more compassionate generation after generation. And our mission is to identify and fund catalytic, transformative initiatives that result in sustainable change. The areas of focus that we developed when it was formed 5 years ago are early childhood care, development, and education, the upstream factors leading to chronic disease, and the quality of life and quality of care of kidney disease and dialysis patients. And the last two of these certainly are led up to this initiative. This is the impact we've had on our community over the last year and a half that the foundation has been active. There's been $310,000 of dedicated to the quality of life and quality of care of individuals with kidney disease. For child care and family services, $770,000, 158 who outreach during COVID. For family housing and resiliency, $420,000, 500,000 shared philanthropy, and $625,000 for community building. So thank you, and please visit the mountbakerfoundation.org, which will help you with the kidney disease questions, but also shows you more about our organization and what we're about.
Excellent. Thank you, Dr. Lombard. There was a question from Bonnie. It says, when one reaches the point at which dialysis is needed, is that end-stage renal disease?
I'm sorry, does that end what?
When one reaches the point at which dialysis is needed, is that end-stage renal disease?
I'm sorry, yes, that is correct. And that is actually defined by having that graph that had the GFR on the bottom. That's defined as a GFR of under 15 when people typically need either a kidney transplant or dialysis, and hence have end-stage renal disease.
Any other questions? Oh, Mary, let me unmute you. Hold on one second.
Yeah, I think the easiest thing for anyone who has a question would be just to unmute and ask the question, and we
Yes, and
can.
first of all, thank you so much for this service. And secondly, I've been taking copious notes for my husband who could not be here to watch this. Did you say that we would be able to see this again if we go? Is this on video or something?
Yes, I'm recording it, so I will edit the recording and I will put it on our Let's Talk About page.
Yeah.
I'll let you guys know when that's up.
So he can, I took a lot of notes, but he can watch it then later. Thank you so much.
For sure.
Mhm.
So, Dr. Lombard, thank you so much for all the information. It was fascinating. And I also wanted to welcome Dr. Paul Schneider. I don't know, Elena, if you can get him to wave his hand or something, but it just so happens that we have two physicians on this call today. So that's pretty cool. Paul, can you find him, Elena?
I found him. He's spotlighted.
Okay. So I don't know, Dr. Schneider, do you have anything that you would like to add to Dr. Lombard's presentation?
There's not much to say. He did a very comprehensive and clear presentation of the issue of chronic kidney disease. I would just emphasize one thing, which you mentioned at the very end here, which is that those who are identified with chronic kidney disease, particularly earlier in their disease progression, that there's very real potential for stabilizing or perhaps even reversing some of that chronic kidney disease. So everybody with a diagnosis is not going to end up with end-stage renal disease, but that requires knowing that it's there, working closely with the primary care provider and the nephrologist. You can actually be somewhat optimistic in a number of cases. But thank you.
Yeah, thank you.
Dr. Lombard, that was wonderful.
Great. Good comment, Paul. Thank you. Appreciate it.
Is that also true with polycystic kidney disease?
I'm sorry?
Is that also true with polycystic kidney disease, that you can possibly avoid it? My kids want to know.
Yeah. And you can, this progression can be slowed by good blood pressure control, the use of certain medications, and now there's a more specific medication, quite costly, but which can slow the progress of that disease. But unfortunately, most people still end up progressing to end-stage renal disease. Paul, I don't know if that's been, if you have anything to add to that.
No, for those who aren't aware, polycystic kidney disease is an inherited kidney condition that if your children want to know, it may be because there's a family history of polycystic kidney disease.
There is, yeah.
But that the fact that most people still progress does not negate the importance of working closely with your physicians.
Thank you.
Yeah.
There is Donita put a question in the chat box for you too. And I am probably going to butcher this, so just have some grace with my pronunciation. But I've taken omeprazole since 2013 and I'm stage 2. Can I control GERD without that drug?
There are certainly other medications you can use to control it. Are certainly worth trying. Drugs like famotidine or Pepcid or ranitidine oftentimes can control the symptoms adequately. But it's also very likely that if you have stage 2 kidney disease, it may not be related to the omeprazole at all, in which case it shouldn't be a problem. So if they checked a urinalysis and found out that she had no white cells or other indications of ongoing damage, it would be okay to continue it.
Great, thank you, Dr. Lombard. There's another question. When one reaches the point at which dialysis is needed, is that end-stage renal disease?
Yeah, and that is correct. That is, the answer is yes. That constitutes end-stage renal disease.
Mary, did you have another question?
Well, my husband accidentally found out that he had kidney cancer because he had a test for diverticulitis. Anyway, it was a small tumor and it was removed, but then that lessened his kidney function, you know, when he lost part of his kidney. I don't know. So I don't know what my question is. It's just a concern that you can't, and the doctor said most people don't even know they've got kidney cancer till it's too late. There's no real symptoms. So I don't know. What do you do to prevent kidney cancer? And how do you find out if you've got it?
That's as best I know, there's no way to prevent kidney cancer. And it is a very difficult to diagnose form of cancer because it oftentimes is not associated with any symptoms. Typically, blood in the urine is one of the manifestations. Rarely it's pain in the flanks is, or a mass is discovered on an examination. And consequently, oftentimes kidney cancers are either found incidentally in the course of another imaging test like an ultrasound or a CAT scan, or after it's already become large enough to cause symptoms like blood in urine and pain and or metastasis. So it's not easy. When it is incidentally found and it only involves a small portion of the kidney, there are some places where they can actually do a partial resection of the kidney and preserve more kidney function.
Yeah.
And I imagine Dr. Snyder, as I have seen individuals over the years who unfortunately end up getting kidney cancer when the other kidney is already damaged, and removing that kidney or having cancer in both kidneys ends up requiring the patient to go on dialysis. It's uncommon, but always a heartbreaker when you see it.
Well, we're going to shift gears here, and thank you so much, Dr. Lombard and Dr. Schneider, for sharing your knowledge with us. And thanks for everybody that logged in today. And we will be having class in about 10 minutes. So if you got to go do something else, get to it. So you're back on time. And thanks again.
Thank you so much.
Yeah, and Tammy, I'll send my slides to you if anyone wants to look at them.
That's
offline.
great.
Okay.
Thanks so much.
Okay.
I can make those